Hello everyone, welcome back to my channel. I am Divya, alumna of Osmania University, your GPAT PGECET mentor. I am super excited to start our CVS Drugs PowerPack session part 1. This session is completely designed for GPAT, PGCET and NIPER aspirants, especially during your exam week with easy classifications, high yield exam points, mnemonics and memory hacks along with smart tips for your quick revision. For those who are new to my channel, my aim is to make pharma preparation simpler and more interesting for students. So stay tuned till the end, take the notes and let's master the CVS drugs smartly together. So coming to the session which involves in the part 1 is generally the first three, that is antihypertensive drugs, antiarrhythmic drugs and anti-anginal drugs. These are discussed in our first part of this power pack session, antihypertensive drugs. Before starting or beginning with this antihypertensive drugs classification, I want to give a small introduction of hypertension. What does hypertension mean? Hypertension in general is never considered to be a disease. It is considered to be a condition where there is increase in the blood pressure or continuous, persistent means continuous elevation in the blood pressure is called as hypertension, and this increase or elevation of blood pressure is calculated or named as systolic blood pressure to diastolic blood pressure. When systolic blood pressure is 140 mm per Hg and diastolic blood pressure is 90 mm per Hg, greater than this numbers generally is considered as hypertension. So they are classified on the basis of the cause. We call it as etiology. On the basis of etiology or cause, these are classified into two, that is primary and secondary. Primary in general, it involves the genetic and the increased RAS. Increased RAS is nothing but our renin angiotensin aldosterone system, which we'll discuss soon here, and increased sympathetic activity, as we already know that generally increased sympathetic activity involves exercise, running, etc. All these will lead to the primary hypertension condition. And coming to the secondary hypertension condition, this is because of already existing disorders such as renal disorders or any kind of Cushing syndrome or hormonal disorders generally result in case of these secondary hypertension. Renin angiotensin aldosterone system. This renin angiotensin aldosterone system is very important. You need to know about this system because our antihypertensives, the first class of antihypertensives will be acting on this renin angiotensin aldosterone system, and this is a multi-organ function system because here it involves kidneys. First major organ which is involved here is kidneys. These kidneys are involved in the release of a substance called as renin. So a decrease in the blood flow to the kidneys is called as the trigger. Trigger means which initiates the cycle of renin angiotensin aldosterone system here. So this causes kidneys to release the renin, and this renin, when it combines with angiotensinogen, and this angiotensinogen is released by another organ, second organ called as liver. From liver we'll get this angiotensinogen, and from kidneys the renin is released. So these two form the two, that is multifunction. In multifunction, one major one is kidneys and the second one is liver. So renin combines with angiotensinogen to form angiotensin 1, and this angiotensin 1 is converted to angiotensin 2. This angiotensin 2, which plays a major role in maintaining our blood pressure. That is because this angiotensin 2 causes or it is involved in three major activities. The first one is it is involved in increased sodium water retention or reabsorption here, and this causes in due to which the vasoconstriction occurs, and vasoconstriction means nothing but increase in the blood pressure. And the second one is it causes direct vasoconstriction. This angiotensin 2 causes direct vasoconstriction of the peripheral blood vessels. This is the second point to be considered. And the third one is it causes the aldosterone release. So as said, as mentioned earlier, it is a multifunction. So here the two main organs involved is one is kidneys, the second one is liver, which releases the angiotensinogen, and the third one here involved, the third organ involved here is the enzyme from lungs. So our angiotensin converting enzyme is being released from lungs. So hence it is called as multi-organ mechanism of action. Okay, that mechanism which is involved in maintaining our blood pressure. So and this angiotensin 2 becomes the major target of our antihypertensives because column in simpler form, where it combines everything. It includes the class, its specific examples, the main mechanism of action here, as well as the adverse effects of the drugs, which are very, very important. And from all our PYQs, from that is the previous year questions of GPAT, PGECET or NIPER, these adverse effects are being asked repeatedly. So I have included this specific column of adverse effects of the drugs along with the prototype drug structure. Prototype drug structure, the class of antihypertensives here, that is RAS, that is our AC inhibitors, ARBs, nothing but your angiotensin, mainly angiotensin 2 here, angiotensin 2 receptor blockers, and the last but not least direct renin inhibitors. So easy mnemonic here to remember is, make a note here, AAR or AAD. AAD means A means AC inhibitors, A means ARBs, that is nothing but angiotensin 2 receptor blockers, and D means direct renin inhibitors. So AAD, this is the clear mnemonic here to remember for RAS inhibitors. And in case of ACE inhibitors, lisinopril, anything which ends with pril, generally when we talk about antihypertensives, it will be the ACE inhibitors. And as we know that already discussed previously, the main mechanism of action involved here is conversion of angiotensin 1 to angiotensin 2, and this is being blocked, because of which it exhibits its antihypertensive activity. Along with that, it causes decrease in the aldosterone secretion, decrease in the vascular resistance. All this happens because the ACE is inhibited. Along with that, these ACE inhibitors are more specific, or another major bonus point to be remembered here in mechanism of action. Along with these three we already know from the flow chart, but another bonus point to be remembered in case of your, in view of your NIPER, GPAT, PGCET exam, is increase in bradykinin. AC inhibitors have the specific mechanism of action of causing increase in the bradykinin. This bradykinin is the peptide which is being generally released, which generally involves in the direct vasodilation. So this vasodilator, which is because it is a bradykinin is involved, it is also an inflammatory stimulator. So inflammation stimulator, hence the adverse effect is dry cough. And here angioedema means the throat swelling, that is the common adverse effect. Along with that, this is a small mistake, you need to get it corrected. This is not hypokalemia, this is a hyperkalemia. And this one point you need to remember, this is common for all the RAS inhibitors. Hyperkalemia is the common adverse effect for all RAS inhibitors. And renal dysfunction, hypotension, these are the common one when we talk about the antihypertensives. In antihypertensives, common will be hypotension, right? Hypotension is the common to ARBs. These end with sartans, losartan and valsartan, and these, as already said, these are angiotensin 2 receptor blockers because angiotensin sartan. Okay, remember this. And here, as already said, adverse effects are common, that is hyperkalemia, hypotension and renal dysfunction. And this is our losartan. This is our prototype drug structure, which is given here, which is shown here. And this will discuss the structural activity relationship and drug structure in detail in our topic video. This is for your revision, so I'm not going, this is a quick revision, so I'm not going in detail. Next one, that is next subclass here is direct renin inhibitor, AAD of RAS. A means AC inhibitors, A means ARBs, that is angiotensin 2 receptor blockers, and D means direct renin inhibitor. The first and best example here is aliskiren and drug structure of aliskiren. Second one, second class here is calcium channel blockers. Calcium channel blockers again further classified into two. That is on the basis of their chemical nature. The chemical nature is dihydropyridines and non-dihydropyridines. Dihydropyridine, this is the ring structure. Dihydropyridine is, this is the ring, dihydropyridine ring, which is makes this classification into two. On the best examples of dihydropyridine, they end with dihydropyridine dipins. Okay, the suffix is dipins, amylodipine and nifedipine. This is a common example, and they block the L-type calcium channels. Especially when calcium ions are present, it means that there is vasoconstriction effect. So once we block this L type of calcium channels, there will be no constriction effect. Instead, that will be converted to relaxation. So relaxation mode will be possible only when we block this L-type calcium channels, predominant vasodilatory effect. And here the adverse effect, this need to be remembered more specifically, is ankle edema. Yeah, what you heard is very correct. It causes the swelling of the ankle, hence it is called as the ankle edema, along with headache, flushing and reflex tachycardia. These are the other common side effects. And here the prototype drug shown here is the amylodipine with dihydropyridine ring in it. And coming to the second one, second subclass of calcium channel blockers, that is non-dihydropyridines. Non-dihydropyridines, from the name itself indicates non means no. No, non means no always. So there is no dihydropyridine. As you see, this there is no dihydropyridine. The mechanism of action is the same because they are the calcium channel blockers, and the best examples here is verapamil and diltiazem, VD. You all know high yielding point or topic to be remembered when you consider the exams. And in this heart and vessels, they cause the decrease in the heart rate along with vasodilation, and contractility is decreased. Okay, contractions, heart contractions and heart rate are being decreased along with this vasodilation. And here if you see the adverse effects, it causes the bradycardia, whereas here this dihydropyridines causes reflex tachycardia. So this is the major difference between these two. And along with that, it causes the AV block, constipation and negative inotropy. So these are the two major differences. Whereas in case of, though they have the same mechanism of action, these calcium channel blockers have those same mechanism of action, they have two different adverse effects, differences in the adverse effects. This is about our two major classes of antihypertensives. One is the RAS inhibitors and the second one is calcium channel blockers. So R, C and next one is D. D is nothing but our diuretics. So when we take these diuretics, diuresis is a simpler mean that increased in sodium and water excretion is called as diuresis. This is the simple definition of hypertensive diuretics. First one is thiazide diuretics, second one is loop diuretics, and third one is potassium sparing diuretics. When we take this thiazide diuretics, thia means sulfur containing group here, and sulfur containing group is there, and azide means again a NH group is already present. Okay, thiazide. Okay, thiazide groups, and these thiazide groups generally these exist along with chlorine in them. Hydrochlorothiazide is the first best example, and chlorothalidone. Okay, both of these have chlorine in them. And coming to the mechanism of action here, they inhibit hydrochlorothiazide and chlorothalidone. So chlorine, they inhibit the sodium chlorine reabsorption in the distal convoluted tubule. DCT is nothing but your distal convoluted tubule, because of which it exhibits the diuretic effect. Diuretic effect is nothing but, as said, that is increase in the sodium and water excretion. Okay, and here major side effects or adverse effects of this thiazide diuretics is hypokalemia and hypocalcemia and hypoglycemia. All these are the major adverse effects of this diuretic, thiazide diuretics. And this is our prototype drug structure, hydrochlorothiazide. As mentioned, these exist with chlorine diuretics. Best example is furosemide. Thiazide you can remember, however, because it is hydrochlorothiazide, from the name itself it is broken down. So loop diuretics, this is be more specific here, furosemide. These inhibits, their mechanism of action here involves inhibition of sodium, potassium and chloride channel. Okay, not only the sodium and chloride, it also involves the sodium, potassium and chloride channel, especially acting on the loop of Henle. And here it mainly causes marked diuresis. Because of this inhibition effect, it causes effective diuretic action. And here the adverse effects will be quite common, but here one point to be remembered here is ototoxicity. Ototoxicity means which is considered to be one adverse effect related to your ears. Okay, coming to the potassium sparing diuretic. Potassium sparing diuretic, the best example here is spironolactone, which is the aldosterone antagonist here, which antagonizes the aldosterone here, and their site of action is collecting duct. So here we are covering the 3 points, not only the mechanism of action, along with the mechanism of action, even the site of action are also being studied here, mentioned. So coming to this, it causes increased sodium ion excretion. Always remember, increased sodium ion excretion means that it is a diuretic effect. Along with that, it is potassium sparing. So it causes even potassium loss. Okay, and here the adverse effect is common, that is hypokalemia. Along with that, it causes gynecomastia and menstrual irregularities. These are the two unique or typical adverse effects when we take the potassium sparing diuretics. And this was asked in our recent GPAT 2026 hypokalemia. Regarding this hypokalemia, what is the major uh, adverse effect of potassium sparing diuretics? So RCB, instead of B we are replacing B with D. RCD, first class is our renin angiotensin aldosterone RAS, and C is our calcium channel blockers, and D here is our diuretics. So R, C, D. And coming to the next major classes of these antihypertensives is our, you can directly take from this A, B, C, D. A is alpha blockers, especially these block the alpha 2 receptors, and B is our beta blockers. These block our adrenergic beta antagonist, we call adrenergic beta antagonist, and these have the suffix, they end with lol, metoprolol, atenolol, labetalol. All the lols come under beta blockers, and they block, from the name itself indicates that they block the beta receptors in the heart, because of which they cause decrease in the heart rate and contractility. Along with that, they are also involved in the decrease in renin release. So remember, this point of these beta blockers is bradycardia, bronchospasm, fatigue, and hypsemia. So these are marked these are the major adverse effects of this beta blockers, and this is our prototype drug shown here, metoprolol, for your better understanding and easy remembering. And coming to the alpha blockers, as mentioned, these majorly block the alpha 2 receptors. So block A is alpha blockers, mainly alpha 2 receptors, because blocking they exhibit the vasodilatory effect, and they end with the best examples here are prazosin, doxazosin, terazosin, all the osins. As in case of beta blockers it is lols, it is osins. In case of alpha blockers osins, prazosin, terazosin, and doxazosin. Here the best example of prototype drug in shown here is prazosin. Okay, this prazosin, this here, these are the adverse effects. These you need to remember. This major differences only you need to remember from one class to another, so it should be easy for you. I made this the this tabular form. So here it is hypotension, which is the first dose effect. Along with that, dizziness, this is wrongly printed, sorry, this is dizziness. Along with it, it causes tachycardia, whereas beta blockers B, bradycardia. The opposite one is caused by alpha blockers. Remember this point. This is most commonly repeated in case of our, when we take our part 2. These are agonists. These two were blockers, and till now we discussed about the blockers. Now this is the agonist here. The best examples are clonidine and methyl dopa. And this methyl dopa is the specific and the first line drug in case of pregnancy. Okay, methyl dopa. And clonidine, this is our prototype drug shown here. This is our clonidine ring structure. Okay, and coming to the main mechanism of action here, as said, these are agonists, means they simply stimulate the central alpha 2 receptors, which causes decrease in the sympathetic outflow and decrease in the peripheral resistance. So decrease in the peripheral resistance is nothing but, we call it as vasodilatory effect, or decrease in the hypertension. Adverse effects, here it causes sedation, that is sleep. Sedation is nothing but sleeping effects, sleepiness, and along with the dry mouth and hypotension. This is quite common, and these are on withdrawal it becomes normal. And coming to the direct A, B, C, and D, here is direct vasodilators directly acting. These directly acting vasodilators means they directly act on the smooth muscle, vascular smooth muscle, and cause the relaxation effect, or we call it as vasodilatory effect, directly acting. And the two major examples here are hydralazine and minoxidil, and the prototype drug shown here is minoxidil. And these, as mentioned, they, from the name itself, it indicates they directly act on the vascular smooth muscle, causing the atriolar vasodilatory effect. And here you need to remember, Here, one major adverse effect here is Loops-like syndrome. Loops-like syndrome is nothing but here drug involved loops-like syndrome. We call it as these are nothing but like common fever, skin rash, etc. are the symptoms of this loops-like syndrome. It's used in pregnancy, and for your easy understanding and better understanding, this is our mnemonic Lady Heart Medical College. L means labetalol. Remember, this is the first line drug in case of pregnancy, and H is hydralazine, which is the drug of choice. Methyl-dopa is also the drug of choice in case of pregnant women, and C means here it is the calcium channel blocker, more specifically, it is nifedipine. This nifedipine, as we have seen in our previous slides, these are nothing but dihydropyridines. These are and this acts as a good antihypertensive drug in case of pregnant women. And here these are the brief note of the doses given. However, this has been shared in our target 2 GPAT PGECET, that is anti-arrhythmics. Here, arrhythmias means nothing but this is irregularity of the rhythm, or any kind of alteration which happens in the conduction as well as the propagation of action potential. Here we need to remember the term action potential, because of which there will be a rhythm. A rhythm means no proper rhythm here of the heart, and here generally the normal resting heart rate will be as 60 to 100 beats per minute here in general. This is the normal heart rate, and in case of bradycardia, this will be heart rate is generally lowered, that is it will fall down to less than 60 beats per minute, and in case of tachycardia the heart rate will be higher than 100 beats per minute, and this is one of the altered rates which causes our arrhythmias here. And ecotopic foci in the atria, these are nothing but your early depolarization, means before the signal has been reached, it already started to work, so that is called as early depolarization. This also results in your arrhythmias. And the third, last but not the least reason or cause for arrhythmias is your misleading action potentials, which generally occur at AV node, which is called as altered conduction. So as already said in the definition here, mentioned in our definition here, in case of this is the general introduction or to know about arrhythmias before going to the anti-arrhythmic drugs here. So coming to our the more specific anti-arrhythmic drugs here, these act on the majorly major point to be considered here, to be remembered here, is action potential. So we need to know about the ECG. ECG is nothing but electrocardiogram. Already you all know about this. Includes all the sum of all the action potentials which occur across the heart cells. Generally, those action potentials which occur across all the heart cells is called as, together we call it as ECG, and this will be in general representation of this action potential of the heart. This is the action potential of the heart, which generally starts from minus 90 MV millivolts to plus 35. In this range only, this action potential occurs in case of heart. So here minus 90, this is called as resting membrane potential, and when we see this action potential is divided into 5 phases here. Remember here the phase 0, as we have seen here, phase 0 is given the importance. So phase 0, which is called as a rapid depolarization state, which is called the this is our first phase, but it is named as 0 here. Remember this point more specifically, though this is the first stage, but this is given the name as 0. The rapid means fast, okay, and it generally involves the opening of voltage gated sodium channels here, or it mainly involved in the influx of sodium ions, and here it corresponds to this is called as QRS complex, QRS complex, or we call it as ventricular depolarization here. And coming to the next phase, the next stage or next phase, that is the phase 1, which is called as initial repolarization. After depolarization, first it will be in the resting stage, then it will be here depolarization occurs, because of which the sodium channels are opened and influx of sodium ions will occur, and followed by repolarization, which is the phase 1, which is the initial repolarization. We call it as, here it involves the potassium outflow, closure of this one and opening of potassium voltage gated channels, closure of this sodium channels and opening of potassium gated channels, as a result of which potassium ions will be going out of the cell. And phase 2, which involves the plateau phase here, this is called your plateau phase here, and it generally involves the calcium influx so as to balance the outflux of potassium ions. So first it will be influx of sodium In and outflux of potassium OK, and again to balance the potassium ions which have left. So to balance that, here there will be influx of calcium ions. Okay, IC, IN, OK, IC. Okay, and here this corresponds to, this is called the ST segment here. And the phase 3, which is called the final repolarization, here rapid potassium efflux it is involved and corresponds to the T wave, or we call it as ventricular repolarization. And last but not least, we call it as our resting membrane potential phase. Here it generally occurs at minus 90 millivolts, and it is in working myocyte, becomes our target site of all the antiarrhythmic drugs. So for your easy understanding, I have represented this in a graph and a simpler note of it, so that you can pause for a while and get a note of this ECG, how it is generally broken down as a phase 0, phase 1, phase 2, phase 3 and phase 4. Phase 4 is the resting stage. Okay, resting potential stage or resting membrane, RMP means resting membrane potential stage it is called. Okay, and coming to the actual classification breakdown here, this majorly involves class 1 to class 4. First one we'll see the class 1 channels. This is nothing but the class 1 anti-arrhythmic drugs. They generally act on the sodium channels. That is our first one, first target site of, because this condition is arrhythmia. In arrhythmia, the condition is generally either tachycardia or bradycardia. Faster, the heartbeat will be either at faster rate or lower rate. So when it is at faster rate, it will block the action of sodium channels in the cardiac cells, and generally on the phase 0, as said, it is the depolarization where sodium channel, sodium ion influx and sodium channel opening cause is taken place. We have seen in our previous slide here. The same part that becomes the target of this class 1 drugs, and here the best example here is quinidine and procainamide. Procainamide and quinidine come under the class 1A. This class 1 again divided or subclassified into 3 classes, 3 subclasses, that is class 1A, 1B and 1C. And coming to the drugs, this is only the chemical structure here I am showing here for your quick revision during the exams. And coming to the adverse effects here, they generally cause worsened proarrhythmia and new, or it is called as worsened proarrhythmia, hypotension and lupus like syndrome, Lupus-like syndrome. The best example of the drug which exhibits this lupus-like syndrome is procainamide. Procainamide specifically, it has the adverse effect of lupus-like syndrome. And synchronism. Synchronism, this all you should be aware that quinidine generally exhibits because it is from cinchona, so it mainly causes synchronism and nausea here. Okay, these are the adverse effects of these two drugs. This is about the class 1A, and coming quickly to the class 1B here, this generally exhibits its mechanism of action of sodium blockade, sodium channel blockade, by shortening the action potential. Here the prolonged action, here it is shortening the action potential. Example is lidocaine and mexiletine. Best examples here, the prototype drug here chosen is mexiletine, and the drug structure is shown here very clearly. Coming to the mechanism of action here, they preferentially used in ischemic conditions, and here they have weak blockade of sodium channels, not much. And 1C, there will be no effect on action potential duration, and here it causes, whereas which prolongs, it has moderate, which shortens, which has weak action, shortens, which is very short, that's why it is weak. Prolong, though it is prolonged, it has PM, moderate action only. Shortens, but it has SW, shorten means weak only. No effect means, though it has no effect, but it has strong blockage of sodium channels, markedly causing the decrease of the conduction velocity here. Okay, and without affecting any action potential here. And when we say, when we take the best examples here are flecainide and propafenone. Here you need to remember, in case of a flecainide, it is a FF, a trifluoro group has been substituted here. So for your better remembering, I am giving this point to be noted here. Trifluoro group is being substituted in case of flecainide, so that you can remember this. Propafenone, you come across this drug structure in your medicinal chemistry. However, in our anti-arrhythmic topic wise revision, we'll discuss this soon. Here it is, they are beta blockers simply. Those were the sodium blockers, here these are beta blockers. And here you need to remember one simple you can say a mnemonic here. This is class 2 3, here they are BPC, that is your beta blockers, potassium channel blockers and calcium channel blockers. If you see specific more clearly here, when you go through this, these all three are blockers again. So BPC is for anti-arrhythmic drugs. NBPC, N means sodium channel blockers. All these are blockers, you remember. All the anti-arrhythmic drugs generally are blockers. Okay, N is N, class 1. Class 1 N. Class 1 N stands for sodium channel blockers. Class 2 stands for beta blockers. Class 3 is potassium channel blockers, and class 4 is calcium channel blockers. Here class 0, this is nothing but HCN channel blockers. This we'll see now. So coming to first the class 2 here, beta blockers, they directly act on the beta receptors which are present, beta 1 beta receptors which are present in the heart. Okay, in the heart, beta receptors are adrenergic receptors which are located in the heart. They directly act on it and exhibit their mechanism of action of anti-arrhythmic activity, hereby causing the decrease in the contractility, decrease in the AV nodal conduction and decreased sympathetic stimulation. All these are, we can see in case of your adrenergic ANS system, this we'll see. So when beta receptors are being blocked, all these activities are being reduced. Is bradycardia and hypotension, bronchospasm, fatigue, depression and worsening of heart failure. Worsening of heart failure, which is quite common with in case of anti-arrhythmic drugs. And here the prototype drugs I have chosen here is metoprolol and propranolol. These are the drug structures, and if you take here propranolol again for your better understanding, it is we can also see MPC in case of beta blockers, that is metoprolol, propranolol, and carvedilol. Okay, and coming to the class 3 drugs here, these are potassium channel blockers, and only lol we can see here. The lol which is in potassium channel blocker is sotalol. So you remember this point. This is a unique one, okay, different one, which is from typical one from other lols. Okay, sotalol, remember more specifically, which comes under the potassium channel blocker. Other examples, well-known examples, are amiodarone and ibutylide, and they block the potassium channel, prolongs the phase 3 repolarization, increases the action potential, and refractory period here. Your refractory period is being increased here, and this also, whenever the refractory period is increased, they cause nothing but QT prolongation, as we have seen in case of quinidine also the same QT prolongation. It causes hypotension, and here amiodarone generally causes organotoxicity here, and thyroid dysfunction, and pulmonary toxicity. These are the major what do you call adverse effects of these anti-arrhythmic drugs, and these are the two prototype drugs, sotalol and ibutylide. So the class 4, that is calcium channel blockers. As the name itself indicates, they block the calcium channels, especially in the AV node, by acting at L type, specifically L type, because they are involved in the vasoconstriction and vasodilation. Okay, the muscle contractions and relaxations are generally carried out by these L-type calcium channels. That's why they act on this L-type calcium channels by causing decrease in the AV nodal conduction. Always remember, maximum of the mechanism of action is decrease in the AV nodal conduction. Here beta blockers also decrease in the AV nodal conduction, calcium channel blockers also decrease in the AV nodal conduction, and decrease in the heart rate, decrease in the contractility. Okay, and best examples are here V and D, verapamil and diltiazem. We commonly remember by our two cricket star names, that is Virat and Dhoni. Okay, verapamil and diltiazem, they are the more important calcium channel blockers here. Okay, and coming to the class 0, that is class 0 is nothing but these act by blocking the HCN channel. HCN channel, not to be confused much, they act on the funny current, we call it as IF, which is generally present in the SA node. Okay, funny current is directly acting on the pacemaker here, which involves both a mixed of sodium and potassium current. Inward current will be acting at this IF, we call it as funny current here. At this point in the SA node, they act and cause the anti-arrhythmic activity without affecting the contractility here. You need to remember this point. There will be no effect on the contractility. And the best example here is ivabradines. These are called as bradines. You remember this. Bradine is the suffix to be remembered for these HCN blockers, we call. Apart from this, this is the general prototype drug structure here. Ivabradine. Bradines means generally the HCN blockers, you remember. And here the other important agents what we generally come across is adenosine and digoxin. Adenosine generally act on A1 receptors, which are present and cause increase in the potassium efflux, and especially acting on the adenosine A1 receptors, AV block. Okay, AV block. Okay, traversing the AV block. And generally these are the drug of choice of PVST here. PVST is nothing but paroxysmal supraventricular tachycardia. So this is the quick revision for your exam week. That's why I'm mentioning only the important points here as per your GPAT, PGCET and NIPER exams. So another specific agent which can be used as an antiarrhythmic drug is digoxin. We already discussed in this specific topic drug, that is digoxin, cardiovascular cardiac glycosides. So in digoxin exhibits its mechanism of action through sodium potassium ATPase pump and causes increase in the contractility, increase in the vagal tone, that is positive inotropy and negative chronotropic effects. And these are the drug structures here. However, we'll see this we'll discuss in the topic wise. It was not possible to adjust into a tabular form. So class 3 adverse effects, especially your potassium channel blockers, amiodarone, sotalol and dofetilide, they cause QT prolongation, what we have already mentioned. Q, as this is nothing but your quinidine also exhibit the same cardiac effect here, bradycardia and heart failure, which is called as your worsening or worsening the existing effect. Okay, and when you talk about amiodarone, in specifically it causes pulmonary toxicity, thyroid dysfunction, hepatotoxicity, ocular toxicity. All these toxicities are concerned with your uh, amiodarone more specifically, along with skin discoloration, rashes and tremors. And coming to our class 4 and adverse effects, specifically here bradycardia, and class 4 is nothing but our verapamil diltiazem, calcium channel blockers, and here they specifically exhibit their cardiac side effects like bradycardia, hypotension, heart failure and AV block. And more specific effects are here, you need to remember gingival hyperplasia and fatigue and dizziness, headache and flushing and peripheral edema. This one, peripheral edema and gingival hyperplasia, these are that is concerned with your verapamil. Verapamil only exhibits this adverse effect, that is gingival means GG, gum tissue. So any issue which is concerned with gum, we generally refer to as gingival hyperplasia. These are hyperplasia. So these are our adverse effects. And coming to the class 1C adverse effects are proarrhythmia, negative inotropic effects, and this more specifically when we talk about propafenone here, it has beta blocking property and cause bronchospasm here. And it here we need to remember another important side effects to be remembered here is characteristic metallic taste here. Metallic taste is exhibited by this propafenone. So this is about the adverse effects, their mechanism of action and classification with subclasses and the examples, more specifically what we have seen about anti-arrhythmic drugs. And coming to the next topic, that is anti-anginals here. Angina means, you know, when supply and demand do not meet, that is called angina. That condition is called as angina here. Means here when the oxygen supply to the heart is insufficient to meet its demand, then that condition is called as myocardial ischemia, or a state is called as angina pectoris, and this causes discomfort in the chest or pain or pressure. These all are the symptomatic symptoms of this angina. This is the general introduction or note of angina, how it occurs, and it is because of the main cause for this is because of any underlying coronary artery disease. And here this radiates, the pain radiates to the left shoulder, arms, jaw, neck or back here. And coming to the types of angina here, a quick view of this picture gives the simple understanding of three types of angina here. I have mentioned these types because only when it is asked in our previous year questions of GPAT, PGCET and NIPER, the types of hypertension, types of angina and tachycardia, bradycardia, here whatever I have shown in this video, those are from my particular research of past 10 years previous year questions of GPAT, NIPER and PGCET. So these are been one or the other ways, direct or indirect questions we will find here. So coming to the three types of angina here, that is the stable, unstable and variant angina. Stable angina, that is called as effort angina here. You remember the other names more specifically here, because they are not asking the direct stable angina or unstable angina. Instead, they are concentrating much on the other names, the also known as alias names. So you need to concentrate much on this. Okay, we can't expect any more direct questions in our entrance exams. And here when we are talking about the stable angina, this is effort angina and it has predictable chest pain. You can predict, you can understand the cause also, and generally the cause will be by exercise, stress or exertion, and this can be relieved by rest sometimes or by taking nitroglycerin. Okay, and generally caused by narrowing of our coronary arteries, as we can see here the stable angina. So this is the primary or stable. You can simply cure, simply, very in simply, as stable and simple. So you can cure it very simple, sometimes by rest or by nitroglycerin, the basic one. And unstable angina, it is also called as crescendo angina here, and this is considered to be a medical emergency here, because here the pain in the chest is unpredictable and can occur even at rest. Though you are not doing any exercise, the cause, the pain in the chest may appear. So, and it is considered to be a medical emergency because it is because of any underlying coronary heart disease. Any coronary diseases results in this unstable or crescendo angina. Okay, you remember this. You see that is unstable angina is also called as crescendo. And variant angina, this is the most asked questions of your GPAT and PGCET, which is also called as Prince Metals angina. And in case of Prince Metals angina, here this also occurs at rest. Okay, mainly at rest, and often here the timings are in early morning or late nights, and it is all caused by coronary artery vasospasm here, coronary vasospasm here. And in case of this, it mainly causes elevation of ST segment here. In case of ECG, when we take, it causes the action potential ST segment elevation of here. And calcium channel blockers are well known drug of choice in case of variant or Prince Metals angina here. And this is the simple diagrammatic representation of stable angina, your unstable angina and variant angina. And we shall discuss about the mechanism of action of organic nitrates here. These are the anti-anginals. These are specific, considered to be the first line drugs or primary choice of drugs. Whatever, whenever angina is there, nitrates will be the first line or drug of choice by in use. Okay, and how does they exhibit their mechanism of action as anti-anginals? Here we'll see that this is a simple pictorial representation for your better and easy understanding. When you go through this simple diagram, it will be very easy in during your exam week to not go through all the notes. It's simple diagrammatic representation. You simply pause during this and have a go through of this mechanism of action of organic nitrates here. Here they exhibit their mechanism of action. First stage is bioactivation, that is generally they will be in prodrug form, so they will be converted to active form, that is by release of nitric oxide here. This is a major nitric oxide, which plays a major role in as in exhibiting the anti-anginal activity here. And this after bioactivation, this is involved in the activation of our soluble guanylate cyclase here. Bioactivation followed by activation, and this after activation of this cyclase here, it causes increase this cyclase SGC causes converts, it is involved in the conversion of GTP to CGMP. TP always is converted to MP. We already know about this in our biochemistry part, and this is being increased here because of increased CGMP. It causes activation of protein kinase PKG here. First bioactivation, activation, increase, again the activation of PKG, that is protein kinase here, and because of which it causes reduction in the intracellular calcium ions. Reduction of intracellular calcium ions generally, which leads to enhanced calcium extrusion also, along with decreased calcium influx. It is involved in the enhanced extrusion. Extrusion means it is outflux, we call it as, okay, sent out, because of which it exhibits the vasodilatory effect on the vascular smooth muscles here, okay. And here, because of this venodilation effect or your vasodilatory effect here, it causes decrease in the preload, decrease in the afterload. So this angina is always in anti-anginals. You need to remember from now. For next few minutes, we'll be talking about this part, that is preloads and afterloads here, okay. And decreased venodilation always decreases the preload, and atriolar dilation results in decrease in the afterload. And here coronary artery dilation, which is the overall effect of this nitrates, is this is simple box. You remember how it exhibits. This is the flow chart shown here, and how is the final effect, the overall effect, that is decreased myocardial. These are the to see here. The benefit here is improved myocardial oxygen supply and reduced myocardial oxygen demand as mentioned here, and relief of angina pain, that is pain in the chest. And along with that, there will be improved exercise tolerance. Though you do much of the exercise also, there will be no pain in your chest. So these are the clinical benefits of the final clinical benefits of our advantages, we call it, of anti-anginals of as organic nitrates. Organic nitrates as anti-anginals, they exhibit their mechanism of action. General anti-anginal drugs, the most awaited one. Here these are divided into the following classes. Here I have made this two, that is IF channel blockers and PFOX inhibitors. These together are generally represented in your textbook's general classification. These are represented as other drugs, but more specifically, I want to be more specific in case of your GPAT, with respect to our GPAT, PGECET and NIPER exam. So I have classified the other agents into IF channel blockers and PFOX inhibitors here, and we'll see this in from the beginning. That is organic nitrates. We have seen the mechanism of action of these organic nitrates. The best examples here are trinitroglycerin and isosorbide dinitrate here. And here prototype drug you take when you take trinitroglycerin here on the 3 oxygens of your glycerin. These are substituted with your in O2 here, nitro groups here, hence it is 3, that's why trinitro. And here this is the glycerin molecule, CHO, if you know specifically. If not, okay, we'll see in our medicinal chemistry breakdown class of this topic again. So this is for your quick revision. You need to remember the drug structure, and here mechanism of action, as we have seen already, by release of nitric oxide. Here it causes its effect as anti-anginal, and here the adverse effects are headache, orthostatic hypotension here. And when you take the apart from this, when it exhibits its mechanism of action, we have seen already in our previous slide, it causes decrease in the preload, decrease in the afterload, decrease in the blood pressure, only increase is in the heart rate. Okay. And when we talk about the second class here, that is the beta blockers here. Beta blockers, the best examples, because they act on the beta 1 receptors which are present in the heart. Okay, here, and exhibit their anti-anginal activity. And here the adverse effects are. Before going to adverse effects, we have a quick view of first the drug here, propranolol. Here, as already we have seen in our previous antiarrhythmics also, the propranolol drug structure, which has a propyl chain here. Okay, three-membered carbon ring, which is being substituted with all here. This is the all OHH is being substituted with the dibenzo group here, and this is the amino group propanol. Okay, and here it exhibits its mechanism of action by blocking the beta 1 receptors and causes decrease in the heart rate, decrease in the contractility, and decrease in the myocardial oxygen demand, and only increase here is the diastolic perfusion time here. And when we take the adverse effect here, it causes the AV block and bradycardia. When we come to the calcium channel blockers here, these are quite common when we talk about anything which causes the heart cardiovascular diseases. If you have seen from the beginning of this video, most of them we'll see in the classification as beta blockers, and calcium channel blockers are quite common. And in case of your anti-arrhythmics, we'll see the potassium channel blockers too. And here we'll see about when we take the calcium channel blockers here, the best examples are nifedipine, which is a dihydropyridine derivative, verapamil, diltiazem, apart from nifedipine. And the prototype drug given here is nifedipine only for your as a prototype drug here. And for a better understanding, this is the drug structure is represented here, and it exhibits its all the calcium channel blockers exhibit their mechanism of action by acting on the L-type calcium channels. By blocking them, they exhibit their mechanism of action, and here they cause the decrease in the contractility. Calcium channel blockade means there will be automatically decrease in the contractility. Remember this. And when there is decrease in the contractility, you need to remember the decrease in the heart rate and decrease in the afterload. But only thing is, here it will be showing exhibiting the increase in the coronary flow. So whenever you take all these three organic nitrates, beta blockers and calcium channel blockers, all the three what I have shown here are decrease, and one will be always increase. Okay, in case of nitrates it is rate. Okay, nitrates increase in the rate, and in case of beta blockers BD, so it is increase in the diastolic perfusion time. In case of calcium channel blockers CC, that is increase in the coronary flow. All others like calcium channel blockers, it is quite common, so you can easily remember. Here nothing to worry much about calcium channel blockers, as these are most commonly repeated from the beginning of our cardiovascular drugs. Coming to the IF channel blockers here, IF means nothing but our funny current, which involves the mixed sodium potassium inward current here, which is located in the SA node, and these exhibit their mechanism of action by causing the negative chronotropic effect. And we have seen even in our anti-anginals, the previous one classification of previous antiarrhythmics also, bradins. So they exhibit their effect by acting on this funny current pacemaker here, and this is generally given in case of patients who cannot tolerate the beta blockers. This is more commonly preferred here. And here they cause decrease in the heart rate, decrease in the oxygen demand, and decrease in the contractility or blood pressure, we call it as. And this is the structure of ivabradine here. And when coming to the adverse effects here, it exhibits the bradycardia. Remember, beta blockers, B bradycardia is a common adverse effect here, and along with that, here IF channel blockers also exhibit bradycardia here. And luminous phenomena is the another adverse effect to be remembered in case of these IF channel blockers. IF phenomena. Okay, when we talk about PFOX, when you break down this is nothing but your partial fatty acid oxidation. We call it as fatty acid oxidation inhibitor, because these generally exhibit their mechanism of action of as anti-anginals by making the heart to rely on its own glucose oxidation. So instead of depending on this fatty acid oxidation, it changes its direction to the glucose oxidation, because of which it reduces the energy intake, as well as in this way it causes reduction in the tissue acidosis, we call it as this one. So because of which it exhibits its mechanism of action as anti-angina. That is what it is mentioned here. Shift in the myocardial metabolism to glucose oxidation, because of which it exhibits its mechanism of action as anti-anginal here. It also inhibits the late sodium current here. And here the the cardiovascular effect specifically is decrease in the sodium channel influx, sodium ion influx, and decrease in the diastolic wall tension is decreased. Only increase here is metabolic efficiency or efficacy is being increased. And the best example is ranolazine. And ranolazine is the chemical structure which is depicted here for your easy quick revision. And adverse effects, when you talk here it causes the QT prolongation, because here sodium channels are involved, so it will be definitely prolongation of QT prolongation here of the action potential. And other effects are quite common here, dizziness and constipation of this PFOX inhibitors. Okay, it not least the potassium channel opener here. Here potassium channel opener best example is nicornadil, and this exhibits its mechanism of action by acting on the ATP sensitive here. Potassium ATP means ATP sensitive. It means ATP sensitive potassium channels antagonize the nitric oxide, because of which it exhibits the anti-anginal activity. And this anti-anginal activity results in decrease in the preload, afterload, and infract size also, and increase in the preconditioning effect here. So as mentioned in this table, everything, most of them will be 3 will be in decrease and 1 will be increase. So more specifically you make a note, except for this IF channel blockers which involves the funny current, IF funny, F for funny current, and though but not to be taken as granted though it is funny, because it involves both the mix of sodium potassium inward current here. Okay, and I am mentioning this because it causes all the decrease here, decrease in the oxygen demand, and decrease in the contractility or blood pressure here. And coming to the structure of nicornadil, coming back to the structure of potassium channel prototype drug nicornadil, this is the structure here. As it is a nitric oxide donor, this is, we can expect the presence of NO2 here in the ring, in the drug structure here. And when we talk about the adverse effects here, the common adverse effect is headache and mucosal ulceration. These are the common adverse effects of this potassium channel opener here. You remember, in case of anti-anginal, it is not a blocker, it is a opener. Anginal, it is a potassium channel. About the quick revision of our 3 main antihypertensives, antiarrhythmics, and anti-anginal drugs classification with memory hacks here. I have clearly memory hacks. Hope these mnemonics, memory hacks, and exam tips would help and easy, especially during your exam. And don't forget to like, share, and subscribe. Target to GPAT and PGCET. soon in the next PowerPack session that is uploading soon. Until then, keep learning, keep revising, and keep believing in yourself. Thank you.